Dear students, welcome to this lecture. Today we are going to look at dysfunctional uterine bleeding, which we touched briefly when we were looking at um, menstrual disorders. So we are going to look at it into details, and my name is Akiden Robina. I'll be taking you through this lecture. This is still part of our gynecological topics that we are looking at. So when we talk about dysfunctional uterine bleeding, or in simple terms, you can say DUB, this refers to abnormal uterine bleeding without any identifiable organic cause. Organic causes like fibroids, cancer, they are not there, they are not identified, and the person is still bleeding. So complaints of irregular or heavy bleeding can be reported by the mother, can either be irregular or heavy, or can be both. Then often related to hormonal imbalances affecting the endometrium or the uterine wall. So patterns of DUB, these include menorrhagia. Menorrhagia refers to excessive blood loss during a normal cycle and is common in women over 30 or with multiple children. Then the other pattern is epimenorrhea. This refers to frequent menstruation, which can even lead to the woman menstruating twice in a month. Then metrorrhagia refers to irregular, non-cyclic bleeding. The bleeding does not follow the normal cycle that it should. Causes of dysfunctional uterine bleeding or DUB. One is anovulation, or we can say anovulatory cycles. So most common cause of DUB, particularly in adolescents and perimenopausal women, is the anovulatory cycles or anovulation. Lack of ovulation leads to prolonged estrogen exposure without progesterone balance, causing endometrial proliferation and irregular shedding. So, when we talk about anovulation refers to the failure of the ovum to be released. Is just the opposite of ovulation. So the when the ovum is not released, then uh, chances are that the progesterone level will also not be able to be released. The progesterone hormone will not be released, and as a result, there will be too much estrogen, which is not counterbalanced by the progesterone, and as a result, can lead to proliferative and the irregular shedding of the walls of the uterus. Then hormonal imbalance, thyroid disorders, polycystic ovarian syndrome, PCOS, and the obesity can also contribute to this, where you find some hormones are lower and other hormones are higher in amounts. Causes of dysfunctional uterine bleeding continue. Coagulopathies, for example, von Willebrand disease, which is explained as a bleeding disorder manifested by heavy bleeding. Then endometrial pathology, endometrial hyperplasia, polyps, or carcinoma in rare cases can also cause the same. Clinical presentation of DUB, heavy menstrual bleeding, excessive bleeding during menstruation, often described as soaking through pads, tampons every hour. So the woman just cleans herself, puts the pad like this, and within short period of time, it is full and she needs to change. This is what we refer to as heavy menstrual bleeding. Then irregular menstrual cycles, infrequent, frequent, or unpredictable cycles. Spotting or intermenstrual bleeding, bleeding between periods or after sexual intercourse. Those are some of the clinical manifestations. So the risk factors for DUB include age. DUB is more common in adolescents and the perimenopausal women due to hormonal fluctuations. So, girls who are still in adolescence due to hormonal fluctuations, they can end up with DUB. Then also those who are nearing menopause can also experience the same. Then obesity increases estrogen levels, contributing to endometrial overgrowth. Then polycystic, okay, PCOS. This indicates irregular ovulation and the hormonal imbalances leading to DUB. Then thyroid dysfunction, both hypo and hyperthyroidism can affect menstrual bleeding patterns. Medications such as use of anticoagulants or hormone therapy can contribute to abnormal bleeding. Diagnosis of DUB. Clinical history, detailed menstrual history, for example, the cycle, length, flow, then the duration. When the woman has her menses this month, is it going to come next month? Or you can ask, after how long will the menses come? Others will tell you 28 days, others will say 30, others will say, it depends, others 26, like that. So whatever they tell you, it will be able to help you to judge whether it is the normal cycle or not. Then flow, does the blood come the normal amount? Is it too little or is it too much? Then the duration, for how long that does the person bleed when the bleeding starts. Then medical history, for example, thyroid disorders, then bleeding tendencies also. This one is very important to be noted. Family history of bleeding disorders or reproductive cancers can also give us a very clue on the diagnosis of DUB. Physical examination, pelvic exam to rule out structural causes like fibroids and the polyps. Laboratory investigations, pregnancy test to rule out pregnancy-related causes, then thyroid function tests, prolactin, and the coagulation studies can also be conducted. Imaging can be done, and under this we have transvaginal ultrasound, hysteroscopy, dilation and curettage for biopsy, blood test for HB levels, and the hematocrit. Nursing diagnosis for DUB. Diagnosis like altered sexual patterns due to abnormal bleeding, anxiety over the possibility of cancer, fatigue due to anemia caused by excessive bleeding. Management of DUB, referral. Patients at the health centers should be referred for investigations and treatment. Stabilization. If severe bleeding occurs, stabilize with IV fluids before referring. Then investigations, comprehensive history, and the physical exams, including systemic disease evaluation. Treatment for DUB, correct anemia if present. Teenagers, estrogen progesterone combination therapy for 3 to 6 cycles can be given. For reproductive age women, rule out pregnancy complications or malignancy first before you proceed with other treatment. And women over 40, investigate for organic causes, for example, cancer, and consider hysterectomy if needed. For example, if it is detected that it is cancer of the cervix, then hysterectomy can be conducted so that it does not spread to the other organs. Then ovulation stimulators, for example, clomiphene citrate for cycle regulation are also management of DUB, medical treatment, hormonal therapy. Here, progestogens can be given to regulate the endometrial lining and control bleeding. Then combined oral contraceptives or COC decrease menstrual blood loss. Then Mirena IUD releases progestogen directly to the uterus, reducing bleeding. Mirena IUD, this is the type of IUD which is hormonal. Non-hormonal treatments include tranexamic acid, reduces bleeding by inhibiting fibrinolysis. Then NSAIDs such as ibuprofen for pain management and reducing menstrual bleeding. Surgical treatment, this can include endometrial ablation, which destroys the endometrial lining for women with refractory DUB. Then hysterectomy, in cases where conservative measures have failed and DUB is significantly impacting quality of life. For example, if the bleeding is excessive, she's overbleeding, meaning she's going to lose a lot of blood. So because of that, or if all the other measures have failed, then the only thing is for the uterus to be removed. When to refer a patient with DUB? Persistent symptoms despite medical treatment. If the symptoms are continuing despite medical treatment, then she has to be referred. Severe bleeding that leads to anemia failure of conservative management after trying hormonal treatments and endometrial ablation. Prognosis and follow-up. Adolescents and perimenopausal women often experience DUB due to hormonal changes. Prognosis is generally good with appropriate management. Chronic DUB requires long-term management with hormonal therapy or surgical interventions for symptom control. So that marks the end of our today's lecture. Thank you.